exam class, so I'll try to tighten the shot group on this. Don't change your answers. You're gonna do it anyways. I just feel like saying it. And then this one I'm kind of big on. So not argue. Maybe argue is not the right word, but I can't. If we want to talk about questions, let's talk about them after class. Is that fair? All right. Dude, a lot of times, like, you'll be passed. There is a good chance that I mark something wrong, and my reviewer, Lieutenant Lyman, might have missed it, right? But don't say anything. And here's what happens: is if like you say something, you're like, "Oh, you're wrong. This is wrong." Blah blah blah, right? And then everybody around you hears that, and then they change it to reflect inaccurately but get it correct. It skews the statistics, and then I can't give it back. It just hurts you in the end. Does that make sense? Made sense in my head. That's a scary environment. So there's a chance that I miskeyed it. There's a chance that I'm going to give it back if it's a high miss. I love giving questions back. I love going to test committee for too many 100 questions. It's the best. Like, did you tell them the test again? I'm like, nope. Like, they're just that good. They just keep getting smarter. I don't know. It's weird. All right. The other thing, this is an optional review. You guys don't want to be here, go downstairs and start practicing. So if you're like, he made us sit here and go through all this stuff, that's not true. If you feel like better time served to be practicing down in the lab, do that. So, all right, going through each of the decks that we talked about. So remember, when examining the tongue, where's it important to look? Sides. Why? What potentially could we miss? Good. Non-healing lesions, something that doesn't scrape off, something concerning for cancer, right? So take a look at that. And what would be our increased risk factor? I don't know if it says it on there. Yeah. Did you say smoking and PowerPoint? Oh, yeah. Smoking and alcohol. It's like PowerPoint could be. I don't know. All right. Remember leukoplakia, oral pre-malignant disorder, kind of has a white plaque-like, unable to scrape it off. Okay. And then risk factors, some of the stuff you just said right here: tobacco, alcohol, HPV. Okay. So what it kind of looks like, scaly, kind of looks like fish scales to me. But are you guys? I've asked this to you before. Are you doing ENT now? Mm-hmm. So you know Weber and Renee then pretty well. All right. So this should just be free chicken, but. There's a couple questions on there. I'm not trying to hide it, but just know how to do Weber, know how to do Renee, know what you're looking for, okay? Have you tested in HENT yet? Have you had questions on that already? Oh, all right. So maybe let's hope they're the same, right? And if I'm wondering, like, hey, what type of questions am I going to ask? This is a physical exam class, so probably know how to do them and know what concerning findings are, what normal findings are, okay? All right, same thing here. Normal, AC, BC, right? Conductive hearing loss, BC, AC. You guys got that. So. All right, nasal trauma. Always, always, always look up the nose. Make sure we're looking at the septum and we're not missing a septal hematoma. Why? Because that can mess up the blood supply, cause necrosis, and you can cause a hole in the septum. Which, go to my first. Did I tell you guys the old lady I had who had a hole in her septum? I ever tell you that story? No, she came in with she had a posterior epistaxis, which is a big deal. She had a posterior nosebleed. But I put my speculum up her nose, and there was clearly a hole right in the middle of her septum. And I'm like, oh man, maybe it was a septal hematoma. Was not a septal hematoma. You want to take a second guess? Cocaine's a hell of a drug. So I was like, ma'am, she was like 80. I'm like, ma'am, you know you have a hole in your septum? She's like, yeah, 70s were good to me. Oh, damn. All right, so then I had to rhino rocket her, put a nasal tampon back there and get it to stop. But I was like, make sure you document that though, right? Like septal hematoma was there before my hands touched it. I don't want that juju on me. So check the nose, check the septum. Always, always, always. Cheilitis, dry lips, licking, sun-exposed areas, angular cheilitis at the angles here. So this is common. You guys will see this in clinic all the time. Cool. And if it's not healing, right? If it's not healing, you see that at the bottom, consider a biopsy to rule out what? Cancer. You guys will talk about it. We don't get too in depth on the pathophys, but again, anything that's not healing, or you get into these ABCDE rules, that's not my realm, but asymmetric, irregular borders, multiple colors, diameter greater than 7 millimeters, and it's evolving. You got to think cancer stuff too. So PTAs. Peritonsillar abscess, these are fun. Uvula deviation, one side, it's an abscess in the back of the throat, right? Concerning? Yeah, right, ungood. It's going to block that airway. So know what we're looking for. So you guys will, that pathognomonic muffled voice or hot potato voice. Drooling, leaning forward, trismus, right? Neck pain and swelling. Man, I feel like I'm going to sneeze. Swimmer's ear, otitis externa. Physical presentation, how it presents. Okay, bacterial most common. Ear pain, pruritus, discharge. Swimming, so get a good history. Yeah, I was swimming this weekend, or they use Q-tips, right? Why do Q-tips cause this? Do you guys know? Yeah, right, skin, surface abrasion. You got normal bacteria, gets in there, opportunistic, creates an infection, right? So who has bacteria in their ear? Everybody, right? Everybody. So God, that looked like my lady's mouth, bottom right. Except those teeth are actually nicer, but oral Canada, so so there's this scrape off, yeah, compared to leukoplakia, and then think about your elderly folks, dentures, maybe antibiotic use or steroid use, and then if you're younger pop, think like immunocompromised, like folks, HIV, AIDS, hematological malignancies, so leukemia, okay, those type of things. Thyroid palpating, how do you palpate a thyroid? Very carefully, right? Very carefully. Now you stand behind them, have them lean forward, relax their neck, swallow, that type of thing. So you guys are going to be practicing that downstairs anyway. Xanthelasma, what are we concerned about? Potentially, yeah, cholesterol, like out of control, hyperlipidemia, which you guys will hit ad nauseum in cardiology and some other classes. But if you've got yellowish buildup on the outside of your eyes and the cholesterol is trying to jump out of your body that badly, like it's probably telling you something, right? So probably want to check a lipid panel on these folks. Pink molecula versus pterygium. So know the difference between those, encroaching on the vision, right? Pink molecula, it kind of does not extend into the cornea versus a pterygium that does, right? Look at your tropias and phorias. Always there versus sometimes. That's your tropia is always, phoria sometimes. A cranial nerve 6 palsy or paralysis. Okay, I would just say what cranial nerve 6 does, how you evaluate it. God bless you. I feel like I got to sneeze too, man. But you hold it in. You hold it in, you'll pop the vessel. Let it out. No? So how do we evaluate this? How do we look at the abducence? Extra ox, good. H pattern, good. Extraocular movements. Your conjunctivitis, right? So if you, I can't remember wouldn't tell you the exact question, but presentation, right? Purulent discharge, red, injected eyes, okay? And then we kind of had a little bit of a discussion or a sidebar talk about, bacterial is pretty easy, I think, to delineate because you see that purulent discharge, bacterial like warm, dark, moist areas. Folks close their eyes at night, wake up, their eyes gooped over, right? Viral versus allergic gets a little bit tough, right? Go with what your HENT instructor says. My concern is that they're not going to stop itching their eyes and it's going to turn into a bacterial conjunctivitis. So I say well, maybe I'll just put them on Tyson at nighttime or something. But anyways, treat how you guys think is appropriate. But if it's bacterial, they need antibiotics. Cover test, so cover, uncover. Go a little bit quicker here, get you guys downstairs. Retinal hemorrhaging, what it looks like. So you guys look in the back of an eye and you see kind of leak fluids or kind of areas of micro bleeding, right? What can be that caused by? Oh, no thanks, man. Thanks. Huh? Yeah, absolutely. Like diabetes is always a good answer. So diabetes, hypertension, right? Those smaller vessels. Okay. Shaken baby syndrome or a blow to the head. So other things to consider. Just always remember, you guys check the eyes. Always check the eyes. Periorbital versus orbital cellulitis, right? So I'd say this one down there in that chart. Extraocular movements. Like hang your whole hat on that, but that's a good delineator between preseptal and orbital cellulitis, okay? If you've got pain with ocular movements, remember that the anatomy of that eye, it's like a cone, it goes back. That bacterial infection is going back in there. There's only so much room to swell. If we're swelling back there and compressing that optic nerve, I think that's a problem. Yeah, it's a huge problem. That's like opto consult, ASAP, hospitalized IV antibiotics versus if you have a superficial infection around your eye, no eye pain removing your eye, give you outpatient antibiotics all day. Just kind of keep an eye on yourself. Subconj hemorrhage. Anybody ever had one of these? No, have you seen them before? People freak out about them all the time, right? Could be very concerning, but it could be a benign issue. So sneeze too hard, they hold their sneeze in. Usually old people, right? Old people fall or something and get this. But different from like a hyphema, if you see like a blood level, right? That's different. That's active bleeding in the eye, in the anterior chamber, versus like broken vessels in the eye. Okay? Could be by choking, coughing, straining, or vomiting. I can't even begin to tell you how many old folks get this from. Do you think old people get constipated? Oh, yeah. They're on the toilet trying to have their daily constitutional and pop vessels in their eye. I'm like, bro, Colace and Miralax, prune juice. Like, it's not that serious. Anyways, this was that hyphema we just mentioned, or I just mentioned. So that's a blood level. That's blood in the anterior chamber, usually from trauma or tearing of the iris or pupil. So that's a little bit different. Argyle-Robinson finding. I think you guys remember what this was called. Prostitute. Nobody remembers that one? No? Prostitute? No? Accommodates, doesn't react. Okay. So remember I told you guys think, oh wait, am I thinking something different? Hold on. No. I'm thinking so remember I told you guys I always thought Argyle-Robinson and accommodates but doesn't react, and I always thought about prostitutes. Prostitute pupil is what it was called. I'm not making this up. Y'all were here when we said this, right?
Yeah, you're talking about syphilis, right?
Right, and I always said, yeah, like, and then when I was in your seat, I was like, all prostitutes have syphilis now. That's how I'm going to make that synapse. But, all right, anyways, I did say that before. I know I did. I say a lot of weird things, but I said that. So JVP, we'll practice this downstairs. Really, what are we looking for?
The waving.
Right-sided heart function, right? So, and every single one of you has asked a great question, and I've had the conversation. How many are you? 71? 72 in here? I don't know. Like, am I really going to do this in clinic? And I told you guys 67 times. I'm not going to lie to you. Have I ever done this to somebody? No. But we got to understand building the physical exam, and then you guys later on will learn, if I'm concerned about right-sided heart function or heart failure, what are some things I could order, right, later on. But if we don't have that baseline of physical exam, then we're failing. So I had CHF exacerbation numerous times this weekend. I didn't have to do this, because when I turned their head, all I saw was like Corrigan's water hairs, like, and then I grabbed their ankles and my feet like stuck in my hands stuck into their feet. I'm like, oh. Right? So it's kind of obvious, but again, I start using my physical exam, and then I know I should probably get a chest x-ray, I should probably get a BNP, I should probably diurese them, admit them, and get an echocardiogram, okay? So you're going to build on that as we go. I don't want you guys to go out there thinking this is the end-all, know-all. But it'd be pretty cool to do it with a patient, I think. So, all right, physiological splitting, so some of your heart sounds, look at heart sounds, aortic valve stenosis, mid-systolic murmur, some of the etiologies and characteristics. PMI, what is it, how do we assess it, right? We look, tangential lighting, we can feel it, right? Those sort of things, you guys got that. Afterload and preload, easy 2 points in the paint, just know the definitions of those. And you guys are gonna need to know this for cardiology, so please look at this, don't remember it, and then Thursday morning, Tuesday morning, whatever morning we take this, just don't dump it. You're going to need to know this stuff. You probably had it before anyways, and anatomy. So S3, extra heart sounds, S3, S4, what are they? Take a look at those. Aortic regurg, some murmurs, some more murmur stuff, right? That's that Corrigan water hammer pulse, which I was talking about, so you can see some aortic regurg with that as well. Holcomb, right? Hypertrophic obstructive cardiomyopathy, so that septum is enlarging. Talked about this one in class. I don't know if you guys remember, I say like every year, you'll hear on the news, like young athletes just drop dead, right? So, you know, that young athlete that's getting fatigued worse and worse and worse because that septum's getting larger, hypertrophy gets so large it blocks that outflow and then they just cardiac arrest. That's bad. So we need to make sure we know how to look for this. So I usually tell my patients, make two fists, lean forward, squeeze them nice and hard, Valsalva, get some of the blood flow return. So, pneumonia, okay, just some information on it. So if I gave you a patient, what sort of physical exam findings would we expect with pneumonia? They're listed on the right there. So febrile, tachypnic, tachycardic, crackles, bronchi, egophony, bronchophony, whispered pectoliloquy, right? All that stuff. So pectus excavatum, right? Caved in chest, pretty easy, I think. I don't remember if I give you a question, if I give you this picture, but just know pectus excavatum, and then carinatum too, the pigeon chest, right? The opposite of it. So if that breastbone's out. So what do we? Does anybody remember we talked? Chris says it right there, Chris. But if this is present and causing complications or issues, what do we do? Refer to surgery, right? So, and again, I'm not going to ask you that, but versus that pigeon chest usually isn't going to cause much of an issue, so or less of an issue, and that's just based off space. Okay. Okay. Sounds: flatness, dullness, resonance, hyper resonance versus tympanic, right? So when we're percussing, what we're listening for. Kussmaul breathing versus Cheyenne-Stokes breathing, so that air hunger or rapid breathing, trying to off-gas. You see that in some of your DKA folks, and then your Cheyenne-Stokes breathing, which is near death. It's like your brainstem kicking in, or agonal breathing. Bronchitis, pathophys, history, exam findings. Take a look. COPD, just a little bit more, kind of showing you that. I guess I don't know why I threw that one up there, but tactile fremitus, right? As we have the patient speak, feeling those vibratory sensations. And again, you guys can see there, it's, what causes increase, sound waves transmitted with less decay in solid or fluid medium, okay? So like your consolidation or pneumonia, think about that. So if you got fluid in your lungs. Again, tactile fremitus, ulnar side of your hands, 99, blue balloons, okay? You guys have been practicing that pretty good. So, same thing, a little bit more here. So pneumonia, tumor, embolism, so something kind of obstructing that tympanic air, something that could be changing the medium of how that those vibrations are traveling, okay? Did anybody go back and take a look at these? I know I couldn't get them to work. You're like, no, you let us out early, we were done. So, all right, don't miss stridor. So that's an airway obstruction. So that high-pitched, inspiratory, kind of, I'm not doing it for you guys can do it yourself, right? I gotta do it. But, so this is an airway closing, or closed from something stuck there. So kiddo maybe ingested something, stuck in the airway. Epiglottitis, maybe it's swelling shut, so this is a bad day. So you guys can see there, don't miss it. If you go in there and you're like, oh, this is stridor, like this is great, this is a good finding, keep doing it, right? That's not good. We should probably be like, ooh, we should probably get some RSI medications and get the card here. Nah, see, it just doesn't want to play. Oh well. All right, I thought this was a good slide. So looking at your obstructive versus restrictive pattern and some of the pathophage behind it. So again, what the problem is, and kind of what your expectations are, some of the things you can't see. So COPD, emphysema, asthma, chronic bronchitis versus scoliosis, obesity, neuromuscular disease, and cystic fibrosis. And again, we're not going to get too into the weeds on the pathophage, but just knowing what you would find in an obstructive versus restrictive pattern. Know your obturator sign, special tests, Cullen's and Gray Turner's. This is internal bleeding. You can see this with pancreatitis, but if your patient has trauma, right? If they're in a motor vehicle accident and they have positive seatbelt sign or bleeding like that, we need to explore. Either doing an EFAST, fast exam, or a CT if they're safe, if they're stable, okay? I had to do a couple fast exams on some folks this weekend. So I had a 28-week pregnant lady that fell down the stairs and landed on her stomach. can't spin her, she was stable, right? So fast exam, up to L&D. I'm like, yeah, let me just do it fast real quick, right? No blood, no fluid, I don't know if there's blood or not, but no fluid in Morrison's, Douglas, anything like that. So I'm like, all right, she's good, she's stable, she can go upstairs. All right, psoas sign, right? Lifting the leg straight up and activation of that psoas muscle. Some findings in cholecystitis. Remember when we talked about? Do you guys remember? Pushing here, taking a deep breath. Everybody remember the name? Murphy sign. Good. Take a look at Murphy sign. Hernias, what they are. Bulging, right? A defect, specifically the epigastric one through the linea alba, right? But this is tissue where it shouldn't be. That somehow made its way through different planes of probably muscle tissue. So, an abdominal bruit. Oh, I had a great case. I had a ruptured AAA this weekend. That was a good one. Yeah. See, it was going to come back to me, but this dude came in with abdominal pain, prior history of stenting in his abdomen. And this was funny because I had a good conversation with my attending, and I referenced you guys because I'm like, all the students are always asking about palpating this thing. Do you guys think with a guy with a history of a AAA with a stent that I was touching his belly at all? Hell to the no, right? There's no way I was touching that belly. Because if it wasn't ruptured and it was already weakened, I'm just going to rupture it, right? So again, kind of reverse engineering it. You got to know kind of what normal feels like and when not to flex your muscles on physical exam. That guy was like, no way. Is he stable or unstable? He was stable. He had good pulses in upper and lower extremities. Blood pressure was equal, but I ended up scanning him and he had like a 6.5 ruptured AAA. It was previously stented and it was like extraving out. I'm like, oh God, nobody move him too much. So get some crash blood, call surgeon, and get him out of there. So that was pretty easy. But what a bruit sounds like, right? Turbulent blood flow, glowing, swishing. You guys got that. So pyelonephritis, CVA tenderness. So we tap the back, right? So upper GU symptoms, painful urination, fever, CVA tenderness. We got to think pyelo. Rovsing sign. I palpate left lower, and I'm stretching that peritoneum, and I'm getting pain over the right side. Where that appendix lies, excuse me. I think I had an appendicitis too. I had a couple appendicitis. Non-comp, non-perf though, so nothing cool. But, rebound tenderness, so pushing down, right? Pushing down and letting go. If it hurts when you let go, that's positive rebound tenderness, okay? Usually you might see this accompanied with peritoneal signs and guarding as well. These folks, if they have a hot belly or an acute abdomen, they don't really want you touching them too much at all, so. But we do that anyways. That was it? No. Was it really? All right.
Oh.
That's fast. All right, let's go downstairs and practice.